Hello, I'm Tim Hartshorne. I'm Professor Emeritus of Psychology at Central Michigan University, and I'm really happy to be able to meet with you today to talk about charge syndrome. And I'm going to be talking about what charge is, how it's diagnosed, and I'm going to spend some time on the various sensory systems which are all impacted by charge. So let me share my screen and we'll get going here. All right, charge syndrome. First of all, what is charge? Well, it is a genetic syndrome. It occurs in about 1 in 15,000 births, although there's some debate about that, but I think that's the best figure. Charge itself is an acronym, so each letter stands for something, for a specific set of birth defects. We don't use the acronym anymore for diagnostic purposes, and I'll explain that a little bit later. And charge is the leading genetic cause for deaf blindness. So here's some other basic information about charge. First of all, not all individuals who are diagnosed with charge will have all of the characteristics. This makes diagnosis obviously a little bit challenging, but also makes the syndrome very interesting. And each of the anomalies, medical problems that you might see with charge can vary in degree of severity. So for example, one might have profound hearing loss or mild hearing loss, or maybe no hearing loss at all, and still have charge. The gene for charge was found in 2004. It's the CHD7 gene. So let me tell you a little bit about this gene. It's the seventh gene within the family of chromodomain genes to have been found. They've since found the eighth one. About 70% of persons who have a clinical diagnosis of charge will test positive. And greater than 90% will test positive if they meet the Blake criteria for diagnosis, which I'm going to explain in a little bit. The gene is a de novo mutation, which means spontaneous. And in most cases, if not all cases, it's due to a copy error in the sperm. Men reproduce sperm all their lives. And when you copy something, copy errors often creep in. And that's what happens with charge, is there's some copy errors in the sperm, which create the mutation, lots of mutations actually, and one of those mutations is charge. So transmission. In most cases, as I said, charge is due to a de novo or spontaneous mutation in the gene. That means the parents don't have the gene. It's not inherited. It's a spontaneous change in the sperm, which didn't affect the parent or the father. Siblings don't have the gene either. However, the risk of a second child with charge is a little bit higher than normal because after all, you had one mutated sperm that produced charge. You may have another one as well. That's a picture of Dr. Connie van Ravensvaart from the Netherlands, who led the team that found the gene for charge. That's actually after I first met her in 2004, 6. It was right after the article came out. So what's the function? The CHD7 has its function during the early embryonal development of the child. In fact, typically it's already done the damage before the mother even knows that she's pregnant. And it works together with many other developmental genes by impacting the neural crest, which is development of the organs, and placoid cell formation and migration. Placoid cells are very much involved in creating the sensory system. So in some cases, the parent could have charge. It's very difficult for a woman with charge to have children, but it can happen. And in that case, there's a 50% risk that the child will have charge. And there's a case of a mother and a child who both have charge. Very importantly, people with charge are so different from one another. Both these women have, or girls have charge. but they're also very much the same. Both of these individuals have balance issues. Both of them have kind of an awkward gait. So, differences, but also there's this underlying commonality of people who have charge. So let me talk about what the CHARGE stand for. Now I have to caution you, we don't use this for diagnosis, but it still is not a bad way to talk about some of the major features that we would see in charge. So one is a coloboma. Coloboma is an incomplete congenital development of various structures of the eye or the visual system, resulting in varying degrees of vision loss or interference with vision. About 80 to 90% of people with charge will have a coloboma, and it can't be corrected with surgery. Basically, in most cases, it's just a missing part of the eye, and it's just missing. So what are you going to do? Some cases of coloboma are iris coloboma. And this is an example of an iris coloboma. You can see kind of the keyhole effect. This is not completely round, but dips down. Well, that dip right there is where the missing piece of the eye is, or missing piece of the iris. This doesn't typically, if it's only on the iris, affect vision, but it may cause light sensitivity because, when the pupil dilates and expands with light, and this part always has, the coloboma always has part of it open. Here's a picture of a normal retina. It's actually a picture of my youngest son's retina. Very proud of his retina. It's good. But this is a retina of my son, Jacob, who's 33 years old and has Charge syndrome. And, it looks white there, doesn't it? That's because there's no retina there. It's just absent. And there's a little bit of a arrow on your right, it says macula. That's the point of best vision, most sharp vision. And you can see his coloboma goes right through the macula. The other, on the left, the notation is for the optic nerve head. And if that's covered, that will affect vision, but not as much as being on the macula will affect vision. Okay, the H stands for heart malformations. And nearly every malformation of the heart that you can imagine can occur in charge. Sometimes it's very small with just a little opening between the two chambers, and it can actually heal on its own as the child grows up. Others are more severe. Tetralogy of Fallot on the left has many blockages and blood flowing the wrong way. It can be corrected by surgery, but it's very, very difficult. The boy on the right passed away when he was about 10 years old. He died from what's known as pulmonary atresia of collateral arteries. This is when the pulmonary artery is blocked. Atresia means it's blocked. But what the artery does then is send out little smaller arteries that go around the blockage and reattach. But they're very small and thin, and it's easy for them to break, and that's what happened in his case. Okay, atresia of the choana, or choanal atresia, as it's also known. This is the A. So choana are the passages at the back of the nose leading to the throat that allow you to breathe through your nose. Deep blockages are called atresia. Narrowing of the passages is called stenosis. Choanal atresia occurs by half the individuals with charge. If it's atresia and on both sides, it will certainly need to have surgery because babies have to breathe through their nose. They're not capable yet of breathing through their mouth alone. So if their mouth is closed and they can't breathe through their nose, they can suffocate. So you need to get the surgery done so they can breathe properly. Here's a picture of choanal atresia. This is pictures looking up towards the nose. And you can see the tip of the nose has two dark passages that go back. On the left side, it's blocked. It doesn't go all the way back to the throat. That's choanal atresia. On the right, it does get back to the throat, but you can also see that there's a very narrow part of the passage, which could be an indication of stenosis. So this person's probably going to be able to, going to need to have surgery so that they can learn to breathe well. Breathing well is an important part of staying alive. The R is for restriction and growth and development. Many individuals with charge will have delays developmentally, maybe smaller than average in their growth. You know, my son is not 5 feet at all and weighs just barely 100 pounds and 33 years old. It's very difficult for him to grow and develop. There's also a wide range of ability in children with charge, from profoundly intellectually disabled children to university graduates. So you can't presume because a person has charge syndrome that they have an intellectual disability. They may not at all. And research shows that about half of individuals with charge have an IQ in the low normal and on up range. About half are below the range for intellectually disabled. G is for genital urinary anomalies. Micropenis and undescended testes are very common in males. Girls can have an underdeveloped labia, about 50% incidence of these. Delays in puberty occur in both sexes, and this is a concern if you want the child to grow up and become a mature adult and to be able to have normal functioning sexual organs, even though they might not produce much sperm. It's also important for bone health. So not going through puberty can be a factor in leading to osteoporosis. There are many different kinds of urinary tract anomalies associated with charge as well, and those would have to be monitored by a physician. Okay, the E is for malformations to the ear and hearing loss. Malformed ears are very common in charge. They tend to be external ears to be floppy with small earlobes. Varying degrees of hearing loss, as I said before, can be mild, moderate, and profound, and it can be different in each ear. And so it's difficult to evaluate, particularly if a child doesn't have good communication skills. Here's some pictures of some charged outer ears, and you can see the different kinds of shapes. Some people have said they can actually diagnose charge by the shape of the ears. I'm not that good, but and you know, one ear might be fairly normal while the other ear is misshapen. It's like everything else with charge. It varies. So that's a picture of Dr. Kim Blake, who was the lead author on an article back in the late 1990s that tried to improve the diagnostic process of charge. Actually, what they did was in 1995 at the International Charge Conference, they had invited the families to go through kinds of a series of small clinics. We met with different experts on different medical issues, and they gathered the data from that, and this led to their diagnostic criteria. So there are 4 C's. We already talked about coloboma. We talked about choanotropenia. We talked about the shape of the ear. But there's also cranial nerve dysfunction. And we have 12 cranial pairs of cranial nerves. And, you know, they influence the function, particularly around the head, but also through the body, like with the vagus nerve and the heart. And Kim Blake and I have done some research looking at the nerves and believe that in some cases it's possible that all 12 nerves are impacted. Now, like everything else with charge, it could be one of the pair and not the other one. But the olfactory nerve is certainly an issue. So sense of smells and problems that we talked about, and all the way down. So this means, especially with surgeries that involve the face and the head, surgeon has to be so careful because those nerves are not necessarily going to be where they think they are. Okay, I want to talk about some of the, oh, I should say, I'm sorry. If you have all four of those C's, you definitely have Charge syndrome. But Tim's team felt also if you had three of them and these two of minor criteria, like heart defects, is a minor criteria, you have Charge. Some people believe if you have two majors and two minors, you have Charge. So even though we seem to have a system where the major things are these four, it's not perfect. It's not perfect at all. So major medical management issues, breathing, right? And we talked about the atresia affecting breathing, but you can also have problems with the connection in the back of your throat, the tubes that go to your lungs, the tubes that go to your stomach. And those can be blocked, interfered with small. Many of the kids need to have tracheostomies put in to help them to breathe. That's something that after some surgery or some additional growth, may be able to get rid of, but it is a problem. Heart defects. Heart defects are a minor criteria only because they're not very diagnostic of Charge. Many genetic syndromes have problems with the heart. So, but the heart defects, if they're not corrected, can cause mortality in people with Charge. Swallowing and reflux. We swallow in a tenth of a second. But kids with Charge, many of them don't. They start to swallow and it stays open and stays longer. And what happens is the food pools in the throat and then gets aspirated through the trachea into the lungs. And that can lead to aspiration pneumonia, which can be very serious. The reflux is when food does get down to the stomach, but they shoot back up the esophagus. Many people have reflux issues. This is a major issue for many children with Charge. And sometimes the whole system has to be bypassed by putting the gastrostomy button so the child is fed directly into the stomach from a little tube that goes from the skin around the stomach from the outside right into the stomach, and you're fed by a tube. Cleft lip or cleft palate are also very common. You know, I have these cranial anomalies, cranial atresia among them, but some of them get the cleft lip or cleft palate. Eating in general seems to be a problem. Some of the children have a really difficult time chewing, and certainly coordinating chewing and swallowing, and don't get enough nutrition through that, and so are fed through their stomach. Motility and gas. Tim Blake's research has shown that the motility of the mass moving from the stomach through the intestines and then out is very slow. And because it's so slow, you can also have a buildup of gas. And so there's a lot of pain around constipation and gas for children with Charge. Ear infections are very common. Eustachian tubes are often not in exactly the right position to drain fluid from the ear very effectively, and sometimes they're very small. It's one of the reasons for the ear infections, and some of the kids go through many sets of tubes in their ears to help drain. That can be a lifelong issue. Puberty, I've mentioned. To go through puberty, many of the kids will need hormone replacement therapy. That is either, through testosterone or estrogen, depending on obviously the sex. And that's, some people don't want to do that because they're afraid, well, they'll become adolescents, they become aggressive. I don't find that to be a huge issue any more than it is with any other child. So I think it's very important to have the hormone replacement therapy. Bone health. I mentioned not going into puberty. One of the problems is osteoporosis can develop. We've had kids with Charge as young as 10 who are at least showing signs of osteoporosis developing. Another issue is the spine. And there's a lot of curvature of the spine. Sometimes the spine is bent, and sometimes scoliosis, and sometimes it's kyphosis where the shoulders are hunched over. Then kidney reflux, I mentioned that sometimes there's some urinary tract problems, and kidney reflux is when urine is shot back up from the bladder into the kidneys, and that can cause damage to the kidneys if it's not identified. And then very importantly, pain. I don't think it's recognized often enough how much pain children with charge and adults with charge live with. They're used to it. They're good at it. They can manage pain better than most of us can, just because they become so familiar with it. It's an ongoing issue. Sometimes they'll say, I don't feel any pain, but it's still there. It's still impacting them. And one of the important things for us to do is to make sure we're identifying sources of pain and getting that treated. Okay, let's look at the sensory deficits in charge. And it's really multi-sensory impairment. Now, if you're deaf-blind, you're dual sensory impaired. But individuals with charge are not just deaf-blind, and some of the individuals may have a deficit in every one of the senses. So that's a picture of my son Jacob, taken by a student photographer. I just think it's great. He's really enjoying the sensation of rubbing his hands on this metal door. So I'm going to just list them off here. We're going to talk about each of them individually, but obviously hearing. And we have lots of sensory neural hearing loss in charge. Vision, we have the colobomans. Smell, it's also called anosmia. It could be a complete lack of smell or a semi-lack of smell. Taste, many of them prefer strong taste because of the lack of smell, for one thing. Tactile sense, some of the kids are very defensive, or some is really kind of painful to be touched or to touch things. And then vestibular problems, the balance issues. And proprioceptive. The proprioceptive sense tells you where your different body parts are and what they're doing at any given moment. And when that's deficient, it's kind of difficult to do things like stand up and walk without taking a lot of care, because I had to figure out where my feet were and how my toes were, and then have to move forward. So we're going to go through these. So hearing. There's a picture actually of my son's both hearing. The external ear and narrow ear canals. Now, the external ear, as it says, misshapen, that doesn't really affect hearing, nor does the narrow ear canals. But it does, because you can still get air through there, but it does make fitting hearing aids difficult. And we've had a hard time. That you see behind Jacob's ear, that's the aid part. It works okay on Jacob. His ears aren't too bad, but some kids have to have those kind of Velcro strap is glued to the head so it doesn't keep falling off and flopping. Middle ear anomalies are very common. Ossicular conductive loss can be large and asymmetric, like everything else, being one side and not the other side. The ossicles are the three little bones. They're really important in terms of taking sound and amplifying it into the middle, into the inner ear. And I said before, the eustachian tubes aren't in the proper elevation and proper space, and that can lead to chronic middle ear infection. The inner ear can be underdeveloped. The cochlea, which are extremely important for passing sound onto the nerve, can have, it's like a shell with curves on it, but for whatever reason in charge, sometimes it has one fewer turns. And exactly how that impacts hearing is entirely known, but it will. As I said before, hearing can be hard to evaluate. I know they worked really hard on identifying what Jacob's hearing was. The audiologist early on was sure he could hear something. We were pretty sure he couldn't. They would see a soft sign of his hearing, and we would say, no, it's just Jacob's mannerisms. Very, very difficult. It turned out we were right and they were wrong, which is always nice for the parent. So hearing loss, normal hearing in charge, about 5% of people in charge may have normal hearing, and that may or may not be in both ears. About 15% have mild to moderate, about 30% moderate to severe, and then about 50% severe to profound. The hearing loss may be progressive and keep going. As I said before, it's likely to be different in each ear, which it is for a lot of us. I have hearing loss and it's different in each ear. Okay, let's talk about vision. When people think about vision, they often think about acuity, because if you have bad acuity, that means you often wear glasses or contacts or some kind of aids. And if you take your kid with charge to an optometrist or even ophthalmologist and have them, look at the acuity, they may well tell you that the acuity is fine. Having nearsightedness or farsightedness is not inherent in charge. It does happen. My son has nearsightedness, as most of his life, but it isn't necessarily there. Coloboma, how much it affects vision depends on its position. As I showed you, if it covers the macula, sharp vision is going to be certainly impacted. If it covers the cranial nerve head, that's going to affect the vision as well. Sometimes they'll say, well, you have a very small coloboma, so it's probably not impacting vision very much. You might have a blockage someplace, but not everywhere. So it varies. But one of the things that's kind of important here is what's called the vestibulo-ocular reflex. Actually, here people call it different things, but vestibulo-ocular, that's good. Let me describe this. So the temporal bones, I mentioned in the inner ear cochlea. I didn't mention temporal bones. These are the semicircular canals and the saccule and utricle. And these control movement. So if you move your head to the right, this fluid goes through the semicircular canals and stimulates them to let you know what your head is doing. If you're going up or if you're going back and forth, the utricle and saccule are impacted. So these basically detect motion for you. And when these are not functioning properly, you won't get dizzy, but your balance will be all out of whack because you don't know where your head is, right? Or when you're going up or you're going forward. It's also true that the cerebellum, we find, can be affected in charge, also impacts balance. So both of these can be very much impacted in charge. In fact, they said, should the temporal bone anomalies be added to the major criteria? It is so common in charge. I hesitate to give a perfect percentage, but I would say 90% of kids with charge have problems with the semicircular canals. And that's why if you watch them, they tend to walk in a very unsteady way and may have a hard time keeping their balance. So I was talking about vision here. So the vestibulo-ocular reflex. When you look at something, so I'm looking right ahead at the screen, I'm going to turn my head, but my eyes are going to stay on the screen. And I go back to the middle and I go to the left, and my eyes can stay on the screen. If you don't have this reflex, when you turn your head, your eyes go with you. All right, so you're no longer looking at the screen. My head is turned, I'm looking over at the door into my office. That's really significant. I was emailing with a young man with charge who was learning to do plumbing. He said, that's why when I grab a tool, it takes me a while to figure out where that pipe is again, because my eyes can't stay on it while I grab the tool. This really impacts vision. You'll have, people say, well, the eyes are fine because the acuity is okay. The coloboma is small. I'll say, well, how are the semicircular canals? Well, they're missing. Well, then the kid is having a hard time with their vision. So functional vision can become impacted. How do kids deal with this problem? they stabilize their heads. A number of the pictures I have included here in this PowerPoint will show kids with stabilized heads. You know, and it seems they're just doing normal kinds of things. But sometimes, and I think I got a man picture later of a boy who said he's down like this while he's working on math problems. That's normal functioning for a kid with charge because they're holding their head steady. When they hold the head steady, then your eyes can focus on what you want to focus on. But if your head is moving because of your balance issues, and you can't really get your eyes easily back to what you were looking at. It becomes very, very distracting. So I wanted to do the vestibular sense next. That's what we were kind of moving into. So balance. One of the things you'll see with a number of kids with charge when they're infants and learning to crawl, they don't really learn to crawl, they scoot. And they scoot on their back, their head down, and pushing with their legs, they scoot across the floor. They often end up with kind of a bald patch in the back of their head because of rubbing against the floor, especially if it's carpeted. Another way that they do this is the 5-point crawl. The picture of a kid doing the 5-point crawl where the 5th point is the head. So 2 knees, 2 arms, and the head. Learning to walk is very difficult for children with charge. They have the vision problems. They have the vestibular problems. They also, which I did some minor criteria, but there's a muscle weakness. They really shouldn't be able to learn how to walk. And yet, 99% of them, I actually never met one who couldn't walk, but I've heard there might be one out there. They figure it out. How they do that exactly, we're not sure. It can take a while. The average age of walking for kids with charge, study after study, is 3. For my research, it's typically the early part of 3, just having turned 3. But the range, some of the kids are walking at 18 months. I haven't heard too many walking much before that. And I've known kids who are 12 years old just figuring out how to walk. It doesn't mean they can't stand and walk supported, but to walk independently. This is pretty much what it takes. I've done a lot of research, and some of my colleagues have done research. Age of walking tends to be a really important marker for how well the kids are going to do in life. Those kids who walk earlier tend to have fewer problems. Those that walk later, more problems. So, for example, adaptive behavior. That's a psychological construct that we talk about kids who can maybe not do reading, writing, arithmetic very well, but they're very good at getting places. They're very good at managing how to spend money. They're very good with kind of daily tasks that don't show up in school. That's adaptive behavior. To wash themselves up, put themselves to bed. They can work the toilet. Those that walk earlier have higher adaptive behavior skills. Challenging behavior. The kids that walk earlier tend to have fewer behavioral challenges through life. Executive dysfunction. Executive functions are the functions of the prefrontal cortex largely that help you to focus your attention, to execute plans, to organize your life in such a way that you can achieve things. Impacted with charge, but particularly for those who walk later. Number of psychotropic medications. I was just curious about this. And yeah, those who walk later were on more psychotropic medications. Communication skills, research by my friend Jim Thalen, who's unfortunately passed away, but Jim found in some of his early research that the kids with the better communication skills had walked earlier. The sleep disturbances. I found that those that walked later had more challenges with falling and staying asleep. So balance is very, very important. And the vestibular sense is very, very important. Does the vestibular sense improve? I don't think it does, but I think the children, as they grow, learn how to compensate for it. And so the walk becomes fairly normal, but they're working very hard to make that happen. Okay. Okay, smell. There was a French study early on where they had, I think, 21 subjects, and every single one of them had no sense of smell. This is interesting. So what you have here are the nasal bulbs, which develop early before the child is born. On the right, and maybe a little bit hard to see, I don't know if my pointer will work, are normal nasal buds. These over here are the nasal buds that kids can charge, and they're missing. So if you don't have the nasal buds, you're not going to be able to smell terribly well. And a lack of sense of smell, interestingly, can affect puberty. So hypogonadotropic hypogonadism is very common in charge. Hypogonadism basically means that you are short on substance that stimulates the hypothalamus and the pituitary and the sex hormones. Hypogonadotropic hypogonadism means that the origin of this is from the nasal area. So this particular hormone starts at the nose and before the child is born and travels along the pathway of the olfactory nerve, the cranial nerve number 1, to the hypothalamus. And in charge, doesn't make it. It may be because the nasal bulbs aren't well developed. I don't know. It might be because the cranial nerve doesn't go where it's supposed to go. I don't know either. But it ends up meaning that the kid can't smell as well as going to puberty. So prepubertal testicular size in adolescence may be very small, absence of secondary sexual development, short stature, lack of ability to smell are all related to hypogonadotropic hypogonadism. This is just a little chart which illustrates there's the hypothalamus. The hypothalamus has to have the gonadotropin producing hormone, and then it stimulates the pituitary. The pituitary stimulates the luteinizing hormone, the follicle stimulating hormone. They stimulate the gonads. The gonads produce testosterone and estrogen. So if those aren't produced, the child's not going to go into puberty. So that's why we need hormone injections in order to bypass this whole system so the kids get the estrogen and the testosterone. Okay, taste. That's my son eating. Obviously, taste is affected by sense of smell. In those days, if you can't smell for whatever reason, things just don't taste quite right. And that may mean that the kid's going to prefer much stronger tastes than we might handle. So Jacob certainly has specific preferences, and they do tend to tend towards the spicy end. It can also impact your desire to eat. If you're not tasting things terribly well, then who wants to eat cardboard, right? By the way, Jacob has to have all his food pureed, so it's absolutely smooth to deal with his swallow issue. So he can actually swallow food and doesn't have to be fed through his stomach. Okay, the tactile sense. This is a really interesting sense that I'm actually just learning a lot about. It has things with tactile perception. How do we perceive things through touch and our body bumping into things, right? It influences our basic emotions. If you have a soft blanket that you use for going to sleep because it comforts you, or maybe you did back when you were a kid, and of course you no longer use it today, but and then also we have tactile based languages. So sign language is in some respects a tactile based language, but there's tactile forms of sign language where sign language right into the hand. It's new stuff. It's new sign language is using the entire body. And then the tactile cognitive processes. So how are we thinking and analyzing and processing information through the tactile sense? This kid in the picture has tactile defensiveness where he really doesn't want to put his feet and hands down on the grass because the grass is a very weird kind of sensation tactilely. And sometimes they won't grip things very tightly. I watched a girl that was supposed to be stirring some stuff, and she just lightly gripped the stir spoon and went like that. She didn't want to touch the whole thing. And the chart shows, tactile touch has with bodily sensations, discriminative touch. It's a light touch, it's a pressure, it's a vibration, temperature and pain, proprioception, which we're about to mention, and then pleasant touch. I will say that by and large, my experience kids would charge, if you're going to touch them, like a firm, hard touch. Not to knock them over, but just like you grab on it rather than lightly touch them, that can drive them nuts. So if you're going to hold on to them, hold on to them with some pressure. Okay, this weird one, proprioception. If I asked you to wiggle your left big toe, most of you could do that right away. For someone with missing proprioceptive sense, it can take them a while to figure out where their left big toe is. In fact, they might have to tap their toes on the ground. Say, okay, that's where it is. So this must be a really weird sensation to be lacking this sense because your whole body awareness is just distorted, where I'm not sure where everything is. In the picture on the left, this boy is in a very typical charge pose, actually. And the arms behind the head let you know where the head is, but also as the head rests against it, it lets you know where your arm and elbows and even into your chest are. And when one foot is over the other, and it gives you some pressure points on the leg, both legs actually, which show you where those legs are and what they're doing. The boy on the right is actually my son Jacob. And if you look at his hands, he's pressing his hands very tightly together. If you do that, you will feel your fingers, you'll feel your wrist, you'll feel your arm, lower arm and your elbow, you'll feel your shoulders, maybe even into the back and neck. It's a great way to find out where your body is. He's also got his lips pursed tightly together. So that gives him information about where his lips are, where his cheeks are, where his jaw is. He's about to go out for a walk. He has taken the sunglasses from his caregiver and put them on his own head. And he's sitting here preparing to go for a walk. And so he's finding out where his body is. He's probably going to start tapping his feet before he gets up so that he can actually walk well. So again, it's kind of the way we feel all our body parts are in relation to each other. And when you're not working, it's difficult to know where the body is and how to prepare for movement. So putting it together, here are 3 individuals with charge who are doing what we call hanging upside down. This is extremely common in charge. The kids will hang upside down. This isn't anything we taught them. Kids with charge are geniuses at figuring out what it is that they need, particularly what it is that their body needs. I asked one time if parents could send me pictures of their kids hanging upside down, and in 24 hours, I had 80 pictures. So this is just a selection, right? So the kid on the left, he's watching TV. Now, that's not how most of us watch TV. And frankly, he's not going to be able to lie there for a long time because the blood will rush into his head. At some point, he's probably going to move. But let me talk about how genius this is. You know how hard it is to hold our head up? All these muscles in the neck and shoulder have to go to allowing us to hold our head up. Plus, the vestibular sense has to be working well enough that we can not have our heads flopping around wherever it might want to go. But, and you don't have to do this, but if you want to try it, hang upside down sometime. Your head is absolutely stable, right? I mean, you're hanging, and so you don't have to worry about what your head is doing. And then your muscles can relax, and you're bypassing the whole vestibular system. It's not an issue. Also, it does away with the problem of vestibulo-ocular reflex, right? Because your eyes are going to be focused on whatever they are, but you're not turning your head's just hanging there. It also helps deal with coloboma. Coloboma, I did not mention this before, it affects your upper visual field. So you often see people with charge tip their head back a little bit. Because my head is tipped back, I can look straight forward. When my head is in a normal position, my whole upper visual field is blocked, and that's where a lot of our vision really is used. So hanging upside down, the kid naturally is looking now through what has become his upper visual field, because he's upside down, he's looking straight ahead. So it really helps with his vision. He's also getting really interesting feedback from the couch that he's leaning on. Notice that his right foot is firmly pressed into that piece of furniture. And his his back and his tush, his bottom are all nicely placed. And also his neck is getting good feedback about where he is. He's getting great proprioceptive feedback. He's bypassing the vestibular issues. And his vision is much better. Lacey in the middle, she's getting lots of proprioceptive feedback as her body can feel where so much of her is, and especially where her legs below her knee are tipping over the chair. She's getting lots of pressure there, which is sending pressure feedback up the rest of her leg and down to her feet. So she knows where they are. And again, having her neck hanging over gives her a chance to relax those muscles and to bypass the vision issues created by coloboma and the vestibulo-ocular reflex. The kid on the right, I often use this picture to talk about what the genius of kids with charge. Nobody taught this kid that the best way to look at an iPad was in this position. Right? You wouldn't think, I'm going to teach you, son, how to. No. But it does the same things we just been describing. His head, I think it's a he, pressed against the couch, gives great proprioceptive feedback. But it's also pretty stable because he's not going to be whipping his body, causing his neck to move because he's upside down. And then he's able to look through the naturally lower visual field, which comes now upward when it's upside down, right at his iPad. So all the senses obviously interact together. And that's important to recognize, that vision, hearing, taste, smell, tactile, vestibular, proprioceptive, these are the ways that we are interacting and contemplating the world. The brain just sits inside our skull. It's got not a whole lot that it can actually do without sensory input. And with charge, the sensory input it's getting is diminished and confusing. So the brain, in trying to sort out what is this world that I'm dealing with here, needs extra time. And we sometimes talk about deaf-blind time. Sometimes kids who are individuals with deaf-blind may stand at a door for longer than we think is comfortable before they reach out and turn the knob and open it. Because I have to take in and organize what is the situation, what's taking place. It also means that sometimes they tune out of the world around them. Way too often, I think they get diagnosed with attention deficit disorder because they're not, and hyperactivity too, ADHD because they're not tuned into what's taking place. They seem to be in their own world, and sometimes they're just moving around in really odd kinds of ways. Must have something wrong with them, but you can see why it would be so difficult when you have these diminished senses to be able to guide yourself to deal with the world, deal with other people, deal with the situation you find yourself in a way that makes sense to the rest of us. So I encourage you when you're working with somebody with charge to put yourself in their experience and see what that must be like and see if that helps you to figure out exactly what's going on. These are members of my research lab over the years. When I retired, we had a reunion and 15 of them were able to come. There were over 40 I had in the lab, graduate students and undergraduate students over the years. They've given me so much joy, such an amazing group of people to work with. I do like to point out that the guy in the back row who was an undergraduate here at Central Michigan also has Charge syndrome. And he emailed me one day and said, I have Charge syndrome. I'd be interested in your lab. So it was great having him in there. He provided many, many very useful insights. So I hope that this has been useful to you. It's been fun for me to talk about this. And I'm always open to receiving email questions. So don't hesitate to try to contact me, and I will be happy to be in touch with you about any of the cases that you're dealing with. So I hope this is useful. I hope that the others in the series are useful, and I wish you all the best.